This presentation will discuss an FP1 CHROME surgery using the C2f technology. The case was completed with Dr. Moody in Ohio, a 42-year implant veteran general dentist who has literally seen it all. Way back with the originators, the implant gurus. He's worked with all of them, and he gave us a wonderful testimonial at the end. Literally 42 years of placing implants, and he said this was his most exciting day of all those years. Boy, is that humbling. Considering this is CHROME guided smile that he used, and it was really a wonderful experience. The original images were they were acceptable, but they were for one purpose, and that was to make sure the articulation was correct, which we accomplished. We had a very nice bite coming in and a perfect bite going out in surgery. So that's what we use those images for. When I arrived in the office, the doctor had everything laid out and uses the MegaGen system. Very nice system for CHROME, being a sleeveless kit system, and of course, one of the nice things is that all the abutments fit all the implants. It's a one size fits all, literally. It doesn't matter what implant you use, you can put any one of their abutments on that implant. Boy, is that easy for making sure you have enough enough abutments on hand for upsizing implants. So he had it all laid out normally, as normal. The SurgiMat had the componentry, and then we were on the wall as well. So we followed the protocols at the beginning, and just like with any CHROME case, fit the pin guide. The pin guide fit perfectly, so we laid a labial flap, and then installed the pin guide to install the fixation base. Doctor used just normal techniques. He did have a particular tool that I was going to share. When he was placing his pins, he used a, keep the volume down here, drilled the pin, put the drill in about 7/8, and then tapped in the pin as normal. However, the tool he used, which was almost like a contra-angle device here, I guess it was devised many years ago, but it has a little rubber stopper on the bottom of it. So if you ever see one of these, I would suggest not using it. We ended up switching over to more of a regular protocol where drilled 7/8, but tapped in with a surgical mallet, and then the handle on a mirror. You take the mirror off of regular mirror, and you just use the shaft of it to tap in the pin, and then it went right in. So that rubber stopper was a little bit of an issue, just in case you ever see one. That was my first experience. Okay, moving on. The patient had bridges, PFM bridges, and temporary bridges, long roots, deep roots, and of course, because it's an FP1, had to be very careful with the buccal plate. So the doctor methodically removed, sectioned the bridge, rotated, removed, piezoed, used a burr around the teeth, and was very, very careful to remove all of the teeth roots carefully, and was very successful. In fact, all the buccal plate was intact, and as you can see here, it's delicate. Delicate situation around the cuspids, around the anteriors. There were some bony defects before we started, and I'll show you the model that we work with. In fact, here's the model. So there were already defects, somewhat. The patient had a long history of dental work, but you'll notice that we prepped the model. This was mounted, articulated. We knew exactly where to prep because of the scallop guide. And so the doctor would just simply look over at that model and then make adjustments. This was a little bit of a spur area, interdental spur, and then in the posterior there was also a divot. He just actually adjusted the divot where the pontic is going to be, and then opened up some areas. Let Let me go to the right slide here. Opened up, actually open up a little bit of this just to make room for the prosthetic, and then made room for the prosthetic everywhere else. So the idea here is that we want the prosthetic to have some size to it, right? To have some strength to it. So it's better to adjust the sockets, the bone, where possible, to maintain the integrity of the prosthetic. It's easy to just remove acrylic on the prosthetic, but then it's weaker. And 6 months down the road, we may have an issue with making the prosthetic thick enough. So there's a little bit of give and take, but follow this model carefully, and of course use the scallop guide, which unfortunately I did not take a picture of. The doctor used the scallop guide only a little bit, just to kind of visualize the size of the sites to prepare, but then really free-handed it because of his experience making room for the prosthetic. So I kind of going on a little bit about that, but that's just so important. The technique for an FP1 is adjusting the bone rather than the prosthetic, especially if you have a thin prosthetic. Now, we did have a little bit of bulk to this one, but I've seen them, where this is the idea is minimally invasive surgery, and often that means minimally sized prosthetic. So don't adjust a prosthetic if you can avoid it. Next step is to place implants, and we had the discussion here where they always look lingual. FP1, FP3, they always look lingual on the guide, but they are correct. He picked 6 straight implants, which certainly makes surgery much easier. Made the restorative part much easier, lining things up, but everything looks lingual, and that's okay. Because that's where we place implants, a little bit lingual. And of course the guide always looks a little bit lingual when it's inserted. Sorry, a little fuzzy picture here, but this is where we just ensure that the fixation base and the fixation base in the mouth look similar, right? So you have a little bit of a gap here, a little more here, and you can visually see that. Make sure the fixation base hasn't moved. It's one of those little checkpoints at some point in the early parts of the surgery. And then of course tells you the long and short pins. So all the sites were relatively simple to drill, to put the implants in. There was one site here where the doctor planned for a horizontal sinus bump, which is kind of rare, but we planned it this way. And fortunately, the doctor is very versed in the Versa system. So what the doctor did was just simply drilled. I believe I have the video here. So the doctor simply did a pilot drill with the Megagen kit, and then went up one size, and then started spreading with the Versa. And so with the Versa, everybody knows what it is, goes in reverse and simply pushes the bone as opposed to removes it. Now you notice that this is still guided. Now this is not a C guide that's made for the Versa, it's a regular chrome guide. But the doctor kind of eyeballed the shank of the burr, of the drill, and then as he slowly got larger and larger with Versa, it was guided. So he was in the perfect trajectory through the whole process. And the size is just about the same. Really worked out nicely with the Megagen system. All right, so bumped it, put an implant in, and we moved on. With this particular case, Megagen, because it's oversized implants, he planned 5.0s. Then we went through the smaller drills with one osteotomy guide and the next osteotomy guide for the larger drills. Pretty simple process. I put this picture in here because you'll notice later that number 8 is a little bit crooked, and we used the wrong mount, and that deviated the implant. It ended up just fine, but just you'll notice as we're going through this. So another trick that the doctor uses, he uses some kind of combination of perhaps a Neosporin and a mineral oil, and he puts it on the drills, which I thought was brilliant. It certainly made the drilling sequence smooth. We never got one hub or drill stuck in the osteotomy guide. They all came out. There was no wedging, which is not common. Implants are in. We tested the prosthetic. The video here. This is a nice thing to do with an FP1 because the doctor uses Explorer and just kind of generally felt underneath each pontic site, underneath each tooth, just to make sure we had enough bone reduced. And did not have to adjust anymore, but I thought that was a nice technique. So if you see any rocking in the prosthetic, it's rocking on bone. And you have to make an adjustment because you have to have room for tissue, because this is bone and then tissue and then prosthetic, obviously. But you also might have some grafting material in some of these sites, and you probably will. The doctor will. So that means you have to make space. And again, this was a thicker prosthetic, so we could take a little bit off the intaglio, but you cannot have zero space here, because once you put the flap back, that prosthetic is not going to fit, and you'll end up adjusting it right when you're supposed to have the final delivery, hours into this. So space is ultimately important on these cases. And you can see here, this is where number 8 deviated. Just from manually putting that implant in. Next step is, there's no carrier guide with a natural case, and that's okay. I've never locked anything in with a chrome, so no gaskets. I don't bother and put gaskets in, because really you can visually stop this material from flowing towards the MUA by just watching it happen. It's an option. You can use gaskets if you'd like. This case, you can see all the abutments lined up, the temp copings lined up. Seat the prosthetic. Do not force the arms into the chrome locks. It has to be passive. If it's not passive, it is hanging up on bone or tissue. In this case, there was some tissue. We removed it. It was passive. He had space. But if you have rocking, address it now. Don't bend the prosthetic. If you bend the prosthetic, then it will not fit on the C2f model properly, and you will not convert properly to the other prosthetic. Very, very, very important, because this will bend, but the long-term prosthetic with the metal reinforcement will not. It will not seat the same. So it must be passive. Okay, you can see I opened up a little bit of number 8. And because these implants were all flared, they were designed flared, then you don't have draw. So the doctor put in these 3, and then from the occlusal dropped in these 3. And they just dropped right in. I opened them up just a little bit, an hour before we went through this process. But from the occlusal on 3, and 3 were already in the mouth, really worked out nicely. Used stellar material to lute, and we ended up using a lot of material, but we were very careful not to put the tip in more than halfway, because you don't want material flowing down towards the MUAs. Fortunately, the patient's lying horizontal, so gravity is going to take it down, not back, but the tip could go in, and I suppose you could theoretically lock it in. So I'm going to play a few videos here on the conversion process of C2f. Just finished surgery, and now we're going to take the natural FP1 prosthetic, which we have picked up in the mouth. Right? Got all the temp copings in here. Actually did a really nice job. It's Dr. Moody in Boardman, Ohio. Did just a fantastic job here. You can see all the depths of the implants are just so. Right? Now it fits into this special C2f model. See, there's no carrier guide with a natural case, so we build the carrier, actually the fixation base, right into the model. And of course, the prosthetic fits right into the fixation base in the mouth, and so it fits into the model. So next, we're going to add the C2f Analogs to the copings, put them in the model and elute it, and we'll fast forward to that. Just a reminder that back in the lab, we always use gold screws. Right? They're special C2f screws, and never OEM. OEM is in the mouth, gold screws back in the lab. So drop a screw in, screw down a C2f analog. That one's a little tight. Won't use that one. We have to always test these before we send them out. And then screw that one down. Okay, 1, 2. Okay, 2 are down, 4 to go. Gold screws, adding the C2f analogs. Okay, we have all the copings in. Now the idea is that this should fit passively into the model. It does not. The implant's deviated a little bit from the plan. Okay, we had a little bit of an issue with number 9. So these are all exactly as planned, right? They're almost never going to be perfectly parallel. We're putting implants in where the bone is. These are all straight in the mouth, but that one has a little bit of an issue. Okay, so I'm gonna take off the analogs off a few of these until there's enough room for them to passively seat, and we'll try that first. Okay, I've taken off the analogs, right? Left the MUA heads on. Now let's see if it fits. My experience is that just doing a little bit of tweaking, there we go, a little bit of tweaking like that makes them fit. You see how precise everything is, but it's just trajectory, right? But the holes in this model have the built-in trajectories, it just doesn't have draw, right? It's all basic lab stuff here. And then so now I'll just add the MUA analogs back on, screw them all down, and we'll leave them on the model. Leave this intact while we cement that all together. Okay, simple technique. All right, another technique is to assemble them outside of the model, because sometimes it's hard to screw down the analog from the intaglio, because it's kind of hard to reach with your fingers. So instead, you can, the screw is still in there. You can now go from the intaglio and drop the the C2f MUA down through the intaglio and just simply tighten it down. It's best if you have a pair of pliers. Hold it steady until it's tight. You know, you have to be very careful that everything is tightened down just so, right? It has to be completely gap-free on every site. Let me zoom in there. So closed, 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 closed. It's all metal to metal. Boy, is that important, right? All these have to be down. If any of these are up, then it will not fit in the mouth. Okay, metal to metal. Okay, now that the prosthetic is down, the next step is to lute the prosthetic, the MUAs, to the model. This is essentially how we create the model. The analogs will be luted to the model. Then we can remove the prosthetic and drill through the long-term prosthetic. So I won't show the full luting process because it's a little long and tedious. But the idea is that you just backfill the gap between the hollow analog down in there and the model. And this is stellar material, so it's a dual cure, and it's about a 2-minute self-cure, 20-second full light cure. And we always take the full maximum amount of time because we do not want anything coming loose. We don't want an analog coming out. So that's one. I'm going to do all 6. Make sure we do it so that the material does not flow above the occlusal part of the model, because we don't want to bond the the prosthetic to the model. Boy, is that important. And then we'll make sure that these chrome locks are down in here when we're hitting it with a light. Okay, coming along here, and remember, always keep the prosthetic this way with the teeth facing out, not up or down, because you don't want the material to flow down the channels and get material on the prosthetic, because then you have to grind the two to separate. Okay, about halfway there. You can see them. I'm going to keep it tilted this way. Okay, one final look before we hit it with a curing light. Looks good. And you see the material, how it does not violate the surface, right? So we don't bond the two together. Okay, we are doing 20-second cures, about 6 of them. Yeah, it's a little overkill, but I want this material 100% cured before we move on. So I'm hitting it a bunch of times. Fully cured. We want a very solid model, nothing coming apart. Okay, the next step is to unscrew the screws, take the MUA heads off, and then attach the long-term prosthetic and drill through. The gold screws that we use are 048. Okay, lab is a lab driver, but any 048, obviously any 048 driver will work. Do not use a different driver. The 048 works perfectly, and that's how it was designed. So I was trying to figure out why the prosthetic is not coming out the model, and it's because I messed up and I got material that flowed all the way through. Nowhere else, just this one site. So now the prosthetic is bonded to the model, and I gotta separate them with a burr. And fortunately, I just took a pair of pliers and just grabbed a little piece of it, almost like a rongeur, and came right apart. So that's no problem. So we'll take it off, catching a little bit there. I'll just remove some more of that, take it off, and move on.